we found in this study was that in our active surveillance population, about 42% of patients who had a PSA of greater than 4 at diagnosis would have been corrected below a PSA of 4 in this study. And so those 42% of patients would never have gotten a prostate biopsy and never have gotten a diagnosis of prostate cancer in the first place. We also evaluated, beyond the active surveillance group, which we evaluated 147 men in, we evaluated a surgical cohort of patients who had Gleason 6 prostate cancer, final surgical pathology, Gleason 7 prostate cancer, and then Gleason 8 through 10 prostate cancer. And what we found when we did the same analysis for those patients is that in the Gleason 6 cohort, about 18% of patients would not have been biopsied. In the Gleason 7 cohort, about 17% of patients would have dropped below the biopsy threshold. But importantly, in the Gleason 8 through 10 cohort, only 5% of those patients who had a PSA greater than 4 at initial diagnosis would have dropped below a biopsy threshold. And so we would have potentially missed those using PSA alone. Obviously, the big downside of, or the limitation to this study is that we looked at PSA alone. We didn't take into account any other clinical factors. So PSA density, family history, DRE, all of those types of things. So certainly we need to factor in these other factors into figuring out who would get a biopsy and who wouldn't get a biopsy, and that'll give us a more robust type of model for who to biopsy in the future. But what's really important is that this is done prior to the diagnosis of prostate cancer. So what we're doing is we're avoiding that initial diagnosis, which then takes us down the rabbit hole of active surveillance, overtreatment, and all the downsides that go along with overtreatment of prostate cancer.